So, we'll talk a little bit about cortical anatomy and just really about how we think about and approach cortical lesions. And so I wanted to go over, what do we mean by cortical? What do we mean by lesions? What kind of things are we talking about? And how do we think about trying to remove them or deciding about whether we need to remove them? For the introduction, I'm an assistant professor of neurosurgery at Weill Cornell. Feel free to email me if you have any questions or you want to talk after the lecture. So to talk about just in broad terms, what are some common pathologies we talk about in the cortex that are neurosurgical or may become neurosurgical? So neoplastic, so anything tumor related, right? So we'll talk a lot about tumors, and I'll go into detail about the most common types of brain tumors that we see. Infectious, abscesses and cysts. Abscesses are commonly from strep or staph. We know the more rare pathologies like neurocysticercosis and toxoplasmosis are very pathognomonic and can sometimes be seen, but is definitely more of the zebra than the horse. Most commonly, when we talk about infection, we're talking about abscesses either from the sinus or from hematogenous spread. Inflammatory, so very common to have inflammatory pathologies. Demyelinating with MS is the most common. We see PML associated with HIV. Sarcoidosis should always be in the differential for intracranial pathologies if we're not quite sure what's going on. And tuberculosis can cause a leptomeningeal inflammatory pathology as well. Sometimes when we see these lesions, it can be very tricky to determine what type of thing it is. We really depend on patterns of enhancement, patterns of signal characteristics on multiple series of MRIs, and we can use advanced imaging if we have any questions about it. But for the most of the time, we have a very good sense of what category things are in, and then we usually need tissue to decide what area within that it is. So congenital dysplasias are common, cortical dysplasias. Those are just things that people are born with irregularities in the gyrus. They may or may not cause seizures or other types of pathologies that are the presenting symptom. Cortical dysplasias, otherwise, if they're not symptomatic, don't necessarily have to be causing a problem. They don't have to be addressed unless or if they're causing new symptomatology. So in the vascular bucket, we talk about cavernous malformations, arteriovenous malformations, and dural AV fistulas. So this is just an example of an AVM. On the left here, you see the MRI. When we look at these little black spots, we call those flow voids. Those are really pathognomonic for an AVM. This is an angiogram showing, where we actually inject the dye into the intracranial vessels, and we see this very large uptake of this tangle of vessels that is an AVM, and it's characterized by these early draining veins. So this is an overview of the most common types of brain tumors. So the most common type, for what you would know, the most common type of benign brain tumor is a meningioma. So when you think about benign brain tumors, really think about meningioma. Now, majority of meningiomas are grade 1. There's a subset are grade 2, and very rarely they are grade 3 or anaplastic. So, but in general, we think about meningiomas as a more benign pathology. Benign doesn't mean that it doesn't cause problems. Benign pathologies can cause a significant local mass effect. They can be very invasive and be major problems. But when we talk about benign and malignant, we're really talking about how aggressive it is and its metastatic potential. For the malignant tumors, the most common type of malignant brain tumor is a metastasis. So 1, 2, and 3. Almost always what we're seeing are metastatic tumors to the brain. Even though we think a lot about glioblastoma, it's actually much less common than a patient with a metastatic tumor. And that's just by virtue of the numbers of people that have cancer. And this number continues to increase. So as the therapies that we have for metastatic cancer continue to improve and our patients, fortunately, are living longer, we're seeing more and more patients with metastatic disease to the brain, even when they're doing really well otherwise. So that is becoming an increasing patient population that we're addressing. So intraaxial or extraaxial. So for those of you that don't know what does it mean to be intraaxial? So this Do we have any, are we able to have any participation, or is it's kind of like a closed webinar?
Yes, I have opened the unmute everyone's microphone so they can participate.
Okay, so feel free to ask or jump in if you have any questions. But so this is an example of a meningioma. It's a very typical example of a skull-based meningioma. We call these types of tumors extra-axial because they're actually arising from outside the brain. So these typically arise from the meninges, from the dural covering typically, and they actually push into the brain. So you might say, oh, well, this clearly looks like it's inside the brain. And it's in the cranial vault, but it's not actually inside of the parenchyma of the brain substance itself. It's actually growing from the covering of the brain, and it's pushing the brain away, pushing the normal brain away. And that's what we call an extra-axial tumor. In contrast, this is very typical of metastatic tumors. So metastatic tumors are typically intra-axial tumors, that they arise often at what we call the gray-white junction, which is where the gray matter meets the white matter, and these vessels end in those areas. And we see these metastatic tumors. We call those intra-axial tumors because they are actually arising from within the brain. So even though they are an abnormal collection of cells that are pushing brain away, they're actually arising from within the brain itself, as opposed to outside of the brain and pushing in. So we're going to focus on cortical tumors, and I think you'll talk in probably other sessions about skull-based tumors and extra-axial tumors, but we're really going to focus on cortical anatomy, cortical tumors, and cortical lesions that are addressed. So when do we need to take something out? Tumors that are increasing in size, creating mass effect, or creating swelling in the brain, which we call edema, causing new neurologic symptoms or a neurologic deficit, or any tumor that we would expect to be malignant that would benefit from resection. We remove vascular lesions. AVMs have a risk of rupture typically of up to 5% per year. That varies depending on how large it is and where it is. But given the risk of rupture, depending on the patient's age, we generally advise that those be removed when possible. And we can talk later about which ones can be removed and which ones can't. But in general, AVMs are considered surgical lesions or lesions that need to be treated in some way. We remove things that cause neurologic symptoms, such as seizures. So cavernous malformations typically can cause seizures, and they, if they're not causing seizures or they're not causing bleeding, they don't necessarily have to be removed. But anything in the brain that isn't normal can cause irritation, cause seizures. If they've resulted in hemorrhage, so cavernous malformations, for example, can bleed. When they bleed, we typically want to remove it because we want to prevent recurrent bleeding episodes. We remove infections when it's an abscess with a really thick or defined wall. And that's because the antibiotics that we give typically don't penetrate this thick wall once it's formed in the abscess. And it's very tricky to treat CNS infections like that. So most abscesses need to be drained or removed. Abscesses or infections that look near the ventricle, near the fluid spaces in the brain, are at risk of rupturing into the ventricle, and that can cause a really severe ventriculitis or meningitis. So those are ones that we pay special attention to in terms of removing and preventing further infection. Inflammatory lesions, so things like MS, those are not neurosurgical lesions. Those are not things that need to be removed. They can even sometimes cause things that look like tumors, but in general, they're not treated surgically. They're treated with medications, with immunomodulators. The only times we as surgeons get involved is if we're really not sure what something is and we need to do a biopsy and we take a sample of it. Otherwise, there's typically not a huge role for resection for most inflammatory lesions. So in terms of how we think about doing surgery on things like this, we first determine eloquence. And I'm going to talk a little bit more about what it means to be eloquent. Eloquence generally just means, does something have a function that can't be replaced by something else in the brain? So does it have a critical function that we rely on for our daily activities? And we'll talk about the different areas that are considered eloquent. We assess at-risk structure. So what is it near? So is it near cranial nerves? Is it near the optic nerve? Is it near major blood vessels that we need to worry about in terms of how we're going to approach it and how we're going to remove it? For cortical lesions, we generally try to choose an approach optimizing both the shortest and the safest trajectory. So in general, we like to say choose the shortest path because you want to go through the least amount of brain to get to anything. So if a tumor, for example, comes to the surface, you want to start your opening right at that surface. So you're minimizing the manipulation of the brain. In some cases, for deeper tumors, it may seem like a path that's short is the best, but if that path is going through an eloquent area, then it might make sense to do a much longer path going through a non-eloquent area in order to preserve function. So we often utilize natural channels, for example, the Sylvian fissure, if we need to access a tumor that is at the back of the Sylvian fissure or in the insula, and we use these natural spaces that the brain provides in order to minimize injury to the brain itself. For skull-based lesions, so those extra-axial lesions we were talking about, like meningiomas, the approach is generally anatomic, so it's guided, it's pure anatomy. We go by skull-based anatomy and we approach it based on the bony anatomy that is needed in order to expose the tumor. And the goal here is really to minimize brain manipulation because we're talking about tumors that are really not arising in the brain, they're arising outside the brain. And so the goal is expose as much as possible and really work in that extra-axial space. You have to know what the safe zones are that can be used to access lesions. And so, in anatomy labs, we've really developed very nuanced approaches to lesions. Almost anywhere in the skull base can be accessed using natural corridors and taking advantage of that. So using advanced imaging is really important. So when we're not sure what the anatomy is or where the eloquence is, we can use advanced imaging in order to get a better picture of both the functional tracts and also where in any given individual where we think the functional cortex is. When we are removing lesions from eloquent areas, we can really take advantage of advanced neuromonitoring. So we're able to monitor patients both for their language, we're able to monitor all of their movements. We're able to monitor their sensory function. And that really helps us to keep patients safe during surgery while removing tumors and other kinds of lesions from areas that otherwise are either close to or within eloquent areas. In almost all cases, what our goal is always to what we call a maximal safe resection, which means we try to remove as much as possible without doing harm. So, very rarely and almost never really are we accepting of a significant neurologic deficit in order to remove something. Unless something is life-threatening, we generally want to remove as much as we can while preserving all of the function that the patient comes in with. So what is eloquent? Well, you could argue that all parts of the brain are important, which is true, but the truth is that there's a great deal of redundancy, and I'm sure Dr. Lewis is going to talk much more about this, but there are certain areas of the brain whose function really can't be reproduced and that are very sensitive to damage. So the main areas that we talk about are the motor cortex. So the motor cortex is the primary motor cortex is located in the precentral gyrus. So this is this kind of side view of the brain. This is the cerebellum. This is the temporal lobe. This is the frontal lobe. This is the central sulcus that divides the frontal lobe from the parietal lobe. This is the occipital lobe. The central sulcus. In front of the central sulcus, we find primary motor cortex. That's where all of the primary motor neurons are. And then behind central sulcus, we find the primary somatosensory cortex, which is where all of the primary sensory cortex is. And this cortex then sends tracts down through the internal capsule, through the brainstem, and that forms the motor tracts that we altogether consider eloquent motor function. There are these areas right in front, this premotor area. There's an area in the sort of middle, immediately just in front of this primary motor cortex. We call that the supplementary motor area. That can actually be really important. It helps patients initiate movement. And so sometimes even if the motor area is normal, if this area is damaged, patients may not be able to move. It may look like they have a stroke because they can't connect the desire to move with the ability to move. Generally, that area, though, has redundancy and it recovers function if damaged, typically over a period of weeks to months at the most. So speech is almost always lateralized. In right-handed people, which is the majority of people, speech is almost always on the left side. Interestingly, even in left-handed people, about 50% of the time, speech is also on the left side. So we're really talking about a vast majority of people for whom the left brain is dominant. So in the left brain, in the dominant hemisphere, if it happens to be right for a left-handed person, we talk about a few major speech areas. So the first one is Broca's area. That's our motor speech area. This is located specifically in the frontal operculum. So this is in the inferior frontal gyrus. So it's the sort of bottom of the frontal lobe. And the correlate to the motor speech area is Wernicke's area. So Wernicke's area is, some people refer to as a sensory speech area. This is, while Broca's area, a deficit there is going to give you problems with producing speech, but you generally have a good ability to understand speech. In Wernicke's area, the reception of speech is really affected, and patients can talk, but they have what we call a fluent aphasia, which is that they're saying words, but they're just not making sense. Now, between those, the speech tract is what we call the arcuate and that tract is, connects the motor speech areas to the sensory areas, among other things, and damage anywhere along there can cause any degree of aphasia, from a partial aphasia to what we call a global aphasia, which is a complete inability to speak, to either understand or produce language. So speech is really one of the, it's the thing that we pay by far the most attention to, and then second would be motor. But speech is really a very sensitive function that is very difficult to get back. So we are very careful for any lesions that are near speech areas. In terms of memory, typically the dominant side hippocampus is very heavily involved with memory, but there are instances where that is not the case, particularly in patients with longstanding seizures and things like that. So the visual cortex is considered eloquent. So the primary visual cortex, the occipital lobe is the primary visual cortex, and then the optic radiations, which is connecting all of the optic tracts, starting from the optic nerves and the optic chiasm, going back into the optic radiations and coming back down into the visual cortex. So, we have to sort of have a really good 3D sense of where everything is in this complex space, because yes, your occipital lobe is here, but you could be near the ventricle, for example, and that's actually where some of your optic radiations are. And so you have to know in any given area what tract, not only what cortex is near you, but what tracts are near you. So to do that, it can be really helpful to use advanced imaging. So fMRIs are functional MRIs. Those are MRIs that we do while people are awake and talking, and we ask them, name objects or, squeeze a ball, and we see as they're doing things, what areas of the brain are lighting up. So we actually get a real-time map of where the function in their brain is. And that can be particularly helpful for patients with tumors that push away normal function into areas that you may not expect. Diffusion tensor imaging, or DTI, so it's a really amazing technology that we have where we can use the MRI to actually extrapolate the white matter tract. So we can actually see where these fibers are in the brain, and we can select the fibers that are near the area that we're interested in. We can look at specifically motor fibers. We can look at sensory fibers. We can look at the visual fibers and the speech fibers. And it can be very helpful to plan surgeries. So in the dominant side, like we talked about, the main areas, we talked about frontal lobe, that's where Broca's is, temporal lobe, that's where Wernicke's is, and then the mesial temporal lobe, that's the hippocampus that we talk about. So this is an example of an fMRI. This is an example of a patient of mine with a very large tumor. If you can see, there's a really bright white spot and this iso-intense hypo-enhancing or really non-enhancing lesion here. This is all what we call a glioma. It's a glial tumor. And so this as you can see, is located not only in the temporal lobe, but also in the frontal lobe. And this is on the dominant side, on the left side. And so we worry about, speech should normally sit right here, and Wernicke should sit right here, and Broca should sit right here. But you can see in this patient, the tumor was really pushing speech up just about to right here. And then we were able to actually track Wernicke's to right here. So that really helped us do the surgery. We actually did the surgery with the patient awake, and we're able to remove all of the tumor without affecting his speech at all. So that's sort of how we use that kind of technology. This is an example of diffusion tractography, where this is a tumor and I was tracking the motor fibers. Motor should normally be right about here, but motor fibers are actually pushed back here. And it really helps us to be able to plan an effective, safe spot to start the surgery. So in terms of neuromonitoring, so we can actually monitor patients' motor function and their sensory function while they're asleep. It's a very useful function. These things we call transcranial motors. I'm not going to go into too much detail about it, but generally we basically put electrodes in the scalp and we transmit signals through the motor cortex, and we can test the whole integrity of the system. So the electrodes are sitting in the head, and then they're sitting on the extremities and all of the muscle groups that we're interested in, and we send the signal down all the way through and then see if it's working. And if we receive a signal in the muscle, then we know that the system, that there's integrity to that entire motor tract. When there's any damage, we can get a reduction in the signal. That kind of tells us, I think we're really close to this area, or we're starting to cause injury here. So it helps us to gauge how aggressive we can be. So somatosensory evoked potentials, those are just the sensory potentials that we use. And then what I use a lot is what we call direct cortical motor stimulation, where we use an electrode and we actually can put it on right over where I expect motor cortex to be. And then we do something we call phase reversal, which basically is kind of this neat tool where we can tell the difference between, we can tell exactly where central sulcus is, because motor cortex and sensory cortex have the opposite directions of their potential. So as soon as we see that reversal in the phase, then we know that is central sulcus, and in front of it is going to be motor, and behind it is going to be sensory. And then we can do something we call subcortical stimulation. So we use an electrode and we can stimulate deep in the brain and find actually those white matter tracts. So that's really helpful. So awake electrocorticography, so that's where we're really we can do direct functional mapping. So we can, with someone awake, we can stimulate and test for speech areas, and we can stimulate a motor area and then keep testing their function. And we can really find exactly where the eloquence is. So this is sort of an example of what patients look like. So these are the scalp, the electrodes. These are some examples of electrodes that are put in the scalp. There's different types. These strip electrodes kind of look like this. They look like a little strip, a little clear strip with small electrodes on it. And we can sometimes use these little numbers to map out the areas of functionality that we're trying to avoid. And this is an example of subcortical stimulation I was talking about, where we use an electrode and we stimulate. This is the motor tract, and we would stimulate in the area that we're working on and kind of get a sense of how far we are from the motor tract. So we might say, okay, well, we're stimulating at 15, we're getting some positive signal at 15. So, we're probably, a couple millimeters away. And so that's really helpful for us. So awake craniotomies. So this is sort of, I use this from the Pacific Neurosciences Institute because I think there is a lot of interest in the idea of using music during an awake craniotomy. I've never done that, but it's certainly the idea of an awake craniotomy is just that we're trying to preserve function, and the best way to preserve function, even when we have a good sense of the anatomy, is to actually be testing function while we're doing it. So if you can keep someone doing the thing that you want to preserve, and you're doing the tumor resection or you're removing the lesion that's abnormal, you can remove more of it if you're able to make sure that while you're doing that, the patient is having good function. And then if there's any sign that they start to falter or start to have difficulty, you can stop. We usually have a neuroscientist with us or a neurologist with us doing the surgeries concurrently so that they're actually testing some nuances to function to make sure we don't miss subtle losses in speech or subtle losses in motor function. These are really, we commonly do these awake craniotomies for dominant insular tumors. Those are sort of like some of the tumors I was showing you before. So these are just a couple cases that just to illustrate kind of when we do what. So this was a 34-year-old male who presented with right-sided weakness. His fMRI did demonstrate that he had, he had left-sided dominance. And so he, because he was left dominant and the tumor's on the left, we actually did a Transilvian resection, which means that we used actually the Sylvian fissure. So this is the Sylvian fissure. We actually split open that fissure, made it wide, and then accessed the tumor through the fissure without actually going through any of the normal brain. Because you can imagine, this is a very short path right here to get to the tumor, very short path to get to the tumor. But the problem is that this is really where we're talking about eloquent speech function. And so if you try to access the tumor that way, you're really going to hurt the patient. So you have to access that through other corridors. There are other ways to do it by finding the tiny little window in the normal brain that you can use to get to the tumor, and that's another way to remove these tumors. But generally, in awake, it's helpful to do it if it's dominant, to do it awake. And actually, so this was an example of this patient was right-handed with right hemisphere dominance, which was really unusual. So because of that, we did it asleep, but otherwise that's how we would do that surgery. This is a 20-year-old male who presented with seizures and word finding difficulty. We planned this with a preoperative fMRI as well as DTIs, and we did an awake frontoparietal craniotomy. We did intraoperative speech mapping and subcortical stimulation to remove the tumor, kind of similar to the other one. One of the problems we run into is that sometimes these tumors, these gliomas, especially these glioblastomas and gliomas, they look almost the same as normal brain. And so one of the tools that we can use is this 5-ALA, which is a fluorescent guided surgery. So we actually just give patients an oral solution, and the tumor actually takes up this 5-ALA, which is a protoporphyrin, and converts it to this visible spectrum. So it converts it to this very bright, avid pink fluorescence. So this allows us to, just to show you an example, in surgery under blue light, we see the tumor here that we're removing is lighting up this really bright pink. So it helps us to say, okay, well, this is normal brain and this is tumor, helps us to remove that tumor. And you can see, like, under the normal white light, it's almost impossible to distinguish, especially as you get closer to the margins. These tumors are very infiltrative. They look very similar to brain. And so it's easy to leave tumor behind, worrying that you don't want to resect normal brain. But when you have something like this that says, we know there are tumor cells in there, as long as it's a safe area, we go ahead and remove it. So in keeping with our desire to do minimal approaches and to try at all costs to remove the lesions that we're talking about without hurting or injuring the surrounding brain, there are many ways that we can approach lesions through a more, what we call, minimally invasive approach. For deep tumors, there is this thing called brain path, which is essentially a concentric tube that we use that we can pass through, often through even a sulci. So we start planning it through a large sulcus, and we can plan the trajectory using our understanding of anatomy and the tracks, and make sure we avoid all those tracks, and then go right to the tumor. We remove this stylet, and then it creates this little tunnel that we have in order to access the tumor safely. And we can remove the whole tumor that way through that tiny little hole. And the craniotomy is extremely small. So even really large tumors that are deep, we remove this way. And we utilize what we call stereotactic guidance, which is that we have a map of the patient's face and their anatomy, and that's from their MRI. That's actually registered with a little reference frame. So we use this little wand, and we can point to any place on someone's head that's been registered, and we know exactly where that is in the MRI. So that helps us plan exactly based on the MRI, sort of like real time, where should we go? And then we can use things like ultrasound to actually get real-time feedback for where abnormalities are. Because one of the problems with using that stereotactic guidance is that once you've changed the brain, once you've started to remove things, may not be as accurate because it's based on an image that you take before surgery. So neuroendoscopy. So we do a lot of neuroendoscopic surgery. We do surgeries for the pituitary gland, for stellar pathologies, paracellular pathologies. A lot of those we can really do through a transnasal endoscopic approach. And so we do a lot of surgeries, what we call transsphenoidal surgeries that way. We can access things kind of here in the frontal lobe, in the plenum region that way. We can access tumors in the clivus that way. So it's really a very powerful tool for skull-based tumors, for anterior skull-based tumors. For neuroendoscopy, transventricular, so we do a lot of ventricular surgeries using an endoscope as well. And so we just do a tiny little burr hole for those surgeries and are able to remove tumors and perform endoscopic third ventriculostomies and treat other kind of intraventricular pathologies that way. These are all minimally invasive, and there are certain complications associated with all of these, but the morbidity relative to much larger skull-based approaches is much less in general. So laser interstitial thermal therapy. So this is a technology, a stereotactic technology using real-time magnetic resonance thermometry, which allows us to place electrodes into lesions that are deep in the brain and in real time ablate it using these thermal probes. So we're actually heating the tumor until the point of cytotoxicity, and we're able to measure the temperature within the lesion and then make sure that the temperature in the surrounding brain remains within a safe level. So that's really a powerful tool that we have to treat things like radiation necrosis, and some deep tumors even can respond to this. And we kind of consider it as an alternative to surgical resection if something is not otherwise resectable or is not accessible.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.